Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Late Relapse of Classical Hodgkin Lymphoma, an analysis of the German Hodgkin study group HD7 to HD12 trials by Paul Jan Bröckelmann et al. My name is Catherine Diefenbach, and I am an Assistant Professor of Medicine and the Clinical Director of Lymphoma at the NYU Perlmutter Cancer Center in New York, USA. My oncologic specialty is Hodgkin and non-Hodgkin lymphoma. Over the last decades, treatment with chemoradiotherapy or chemotherapy platforms such as ABVD have resulted in long-term cures of most patients with early-stage good-risk Hodgkin lymphoma. This has led to a shift in the therapeutic focus for these patients to the reduction of treatment intensity with a goal of avoiding potential long-term toxicities such as secondary malignancies, infertility, organ damage, or impaired long-term quality of life. The general assumption has been that patients who are in remission for more than 5 years after the completion of their therapy are cured of their Hodgkin lymphoma. To date, the phenomenon of late relapse of classical Hodgkin lymphoma has been studied only in small case series and has not been well described. In this important study, published by the German Hodgkin Study Group, the authors demonstrate in the largest case series to date that the risk of late relapse from Hodgkin lymphoma, although rare, remains persistent even 5 years after therapy and may increase with time, especially in early-stage patients who are treated with minimal therapeutic intensity. The authors retrospectively analyzed 6,840 classical Hodgkin lymphoma patients enrolled in the German Hodgkin Study Group trials HD7 to HD12, spanning a period of 20 years from 1993 to 2003. They report on the 4,794 patients who qualified for one of these trials, responded to first-line therapy, and were relapse-free for at least 5 years. Patients who had relapsed after more than 5 years in remission were compared to patients with ongoing remission who had not relapsed, and to 466 patients who relapsed within 5 years of their initial diagnosis, treated on the same trials. 141 of 4,794 patients, 3%, experienced late relapse Hodgkin lymphoma with a median observation time of 10 years. The incidence of relapse increased in a linear fashion with time, 2.5%, 4.3%, and 6.9% at 10, 15, and 20 years respectively. No plateau for late relapses was seen. Late relapse Hodgkin lymphoma was more frequently seen in patients with early favorable compared to unfavorable or advanced stage disease at initial diagnosis. This trend was confirmed by multivariate Cox analysis and also identified older patients and male patients to be at higher risk of late relapse. Overall survival from diagnosis was worse after late relapse compared to patients who did not experience a relapse, with a 10-year estimate 95.8 versus 86.1, but better than for patients demonstrating an early relapse. The authors conclude that Hodgkin lymphoma survivors have an 85-fold risk of recurrence of disease compared to the general German population, and that Hodgkin lymphoma survivors should continue to undergo surveillance for timely detection of late relapse. However, with appropriate salvage therapies such as stem cell transplantation, many of these patients can be salvaged. The prognosis of late relapse Hodgkin lymphoma is superior to that of early relapse. This article is important because it challenges the general paradigm that patients treated for Hodgkin lymphoma who are in remission for more than 5 years after completion of therapy are cured of their lymphoma. In the era of therapeutic minimalism and risk-adapted therapies, the observation that early-stage patients experience a significantly higher incidence of late relapse than advanced-stage patients raises the question of whether these patients may be undertreated. The authors report that they did not observe any difference in the incidence of late relapse with German Hodgkin study group trial generations incorporating even less intensive therapeutic regimens, argues against this point somewhat, although not completely, as the duration of follow-up for these generations of studies are different, and we may yet see differences in 15 and 20-year PFS between trial generations. The important questions raised by this paper are: what are late relapses of Hodgkin lymphoma, and why do they occur? Who do they occur in? Ultimately, there are, as of yet, no definitive answers, but I outline several hypotheses below. First, we must ask the question, are these late relapse Hodgkin lymphoma truly relapse disease, or are they a second de novo incidence of Hodgkin lymphoma? The authors argue that a standard incidence ratio of 84.5 for the recurrence of Hodgkin lymphoma compared to the age and sex-matched German population argues against de novo or accidental disease. They also evaluated the incidence of switching between classical Hodgkin lymphoma and lymphocyte-predominant Hodgkin lymphoma, which was quite low, and conclude that this supports their hypothesis of relapsed rather than de novo disease. However, if one considers that patients with a history of Hodgkin lymphoma may have enhanced susceptibility to Hodgkin lymphoma due to innate immunologic susceptibility, chemotherapy-induced immune dysregulation, subsequent environmental stressors such as viral infections, or some combination of these, then it is possible that these patients could have a substantially higher vulnerability to a second primary tumor than the general population which does not share these susceptibilities. The interesting finding that many late relapse Hodgkin lymphoma, while still classical Hodgkin lymphoma in histology, had switched their histologic subtype or were redefined as unclassifiable may support this hypothesis. How one considers this question may influence what one considers to be the driver of late relapse in Hodgkin lymphoma. If one believes that these late relapses are truly relapses of the original disease, one possible explanation is that the good risk early-stage late relapse Hodgkin lymphoma patients who received radiation alone in HD7 or 2 cycles of ABVD chemotherapy plus radiation in HD10 may be receiving therapy which is of borderline sufficiency for long-term cure beyond the 5-year time point. The published data for both of these studies describes a 5-year progression-free survival. While late relapse is rare, it does appear to persist up to at least 20 years without a plateau. Perhaps a progression-free survival of up to 10 or 15 years is necessary to conclude a sufficient curability for a minimal intensity regimen. A second explanation is that there is something unique in the Hodgkin lymphoma biology of the late relapse patients, either inherent in the Hodgkin-Reed-Sternberg cells, which persist in an indolent fashion despite chemotherapy, distinct features in the immune microenvironment that are uniquely tumor protective in these patients, or an innate susceptibility to a second primary tumor. The authors report that late relapse Hodgkin lymphoma is more often found outside the initially involved and treated sites of disease. Analysis of paired biopsy specimens, if possible, should be undertaken to resolve the question of how the biology of these late relapses, both in the tumor or the microenvironment, differ from the original disease, and what these substantive differences are. Going forward, this data suggests that one goal of prospective trials in good-risk early-stage Hodgkin lymphoma patients should be to improve risk stratification, which will allow us to more precisely target therapeutic intensity to individual patient risk profiles and minimize the risk of late relapse. This also underscores the importance of additional longer follow-up beyond the 5-year progression-free survival benchmark in future prospective trials of this patient population, as well as reporting of 10 and 20-year progression-free and overall survival in early-stage patients treated in trials with risk-adapted therapies in the U.S. and in other European countries. Finally, careful comparison of early and late relapse biopsy specimens may help us to resolve the question of whether these late relapses should be considered de novo disease. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.